This meeting is being recorded.
Let me know once everybody joins.
Sir, we'll start, sir.
Shall we start?
Yes, sir.
Okay. Everybody join?
Sir, recording has been started, sir.
Is my voice is clear?
Yes, sir, it's clear, sir.
Okay, we'll start?
Yes, sir.
Okay. Hello, good afternoon to everyone. Myself, Dr. Ganesh, consultant neurologist in Nanjap Hospitals, Davangere. I did my UG from JJM Medical College. Sandeep sir was my senior. PG from Kim Subli. Your Nizam is also my batchmate. Did DM Neurology from MC New Delhi. Okay, we'll start. Before going in detail, we'll discuss about the epidemiology of headache. All of you know most of the patients in the OPD visits, they will be having headache. 30% of the patient will be having migraine. And most of the patient will have chronic history of headache. That is more than 15 days in a month. This is the fifth leading cause of emergency visit and third highest cause of disability. Most of the headaches are primary headache disorders. Only 10% constitute around secondary headaches. Headache patients are in pain, often depressed and frustrated. When you evaluate such a patient, therefore you need to establish proper rapport and you need to ask the right questions. So patients who responds to physician who responds.
Sir, excuse me,
Before
sir.
going,
Sir, the slides are not changing, sir.
not visible.
Sir, can you share? Now it's coming, sir.
It's visible.
Yes, sir. Sir, can you just press on the presenting button, sir, the screen share button?
Now?
Just a second.
Now?
It's not coming, sir. Sir, can you share the PPT, sir? I'll share the screen and you can present and I'll change whenever you tell to change.
Okay, I'll share in the WhatsApp. Okay.
Yes, sir. Yes, sir.
Just see the group one I sent.
Sir, we'll start, sir. Whenever you want to change me a slide, just tell next, sir. I'll go to the next slide.
Okay. Next. I think few slides are there. Go to slide number 3.
This one, sir.
Next slide. Okay. All of us know there are pain sensitive structures in brain that causes headache. Okay. Few structures that are present inside the intracranial. That is the arteries of circle of Willis, medium-sized branches, dural arteries, large veins, dural venous sinuses, durameter near the blood vessels, pyometer, and small cerebral vessels. These are all the pain-sensitive structure. Whenever the lesions or infection or inflammation that is involving these structures will causes the headache. And some of the intracranial structures also causes headache, like external carotid arteries, as you see in carotid artery dissection, periosteum, fascia, scalp and neck muscles, skin and cutaneous nerves, cervical nerves and nerve roots, mucosa of the sinuses and teeth that do have also pain-sensitive structure. Even any lesions or any inflammatory condition affecting these structures will cause us the headache. Next slide. Just we'll go through the classification of the headache. The recent one is International Classification of Headache Diseases 3. Is the recent version. This one is classified as Part 1, Part 2, and Part 3. In Part 1, mainly primary headaches are included, like migraine, tension type headache, trigeminal autonomic cephalgias, and other primary headache disorders. In secondary headache, they have included headache that is attributed to trauma, injury to the head and neck vessels, head and neck structures, and intracranial non-vascular disorders, and headache secondary to substance abuse, CNS infections, disorders of the homeostasis, and structures, lesions that are involving the cranium, neck, eyes, ear, nose, and sinuses. And headache that is attributed to the psychiatric disorder. All these classified under the secondary headache. And third one is painful cranial neuropathies. As you all of you know, trigeminal neuralgias and other facial pains that are classified under the Part 3. Next slide. Let us come to the history taking in a patient with headache. It's an art. First, you have to tell the patient to first you have to allow the patient to speak first, and you can get history from spouse and relatives also. In a pediatric patient like age less than 5 years, it will be difficult to take history, so they can ask the reliable attender. And patient will be having multiple chronic pain complaints. You have to prioritize. You have to rank the pains according to their impairment. You should listen to the patient quietly, and that will help you in the diagnosis. Next. Whenever you are taking the headache history, you need to see for the red flags, because red flag that indicates secondary headaches. So whenever you have red flags, you need to evaluate and you need to treat the condition according to the cause. Any new onset headache, atypical and severe headache that warrants the imaging. Therefore, clinician should be alert. Overlapping features of the primary and secondary headaches should be evaluated, because primary headache patient might be having secondary causes also. That time you need to evaluate unless only treating the primary headaches. You have to see the temporal profile, onset, progression, associated neurological deficits that will help you to the arrival diagnosis. Next slide. These are the following are red flags. The patient elderly, more than 50 years, rapid worsening of the headache with strenuous exercises, and sudden onset thunderclap headache. Systemic illnesses like patient having fever, rashes, or any worsening pattern of the headaches. These will help you to diagnose the condition. If patient more than 50 years, that indirectly indicate any structural lesions or any temporal arteritis. Rapid onset with strenuous exercises that will indirectly indicate the intracerebral hemorrhages. A thunderclap headache. All of you know what is thunderclap headache? Anybody can define? Anybody can define? Okay, thunderclap headache is like a symptom onset headache that will peak within 60 seconds. That is within 1 minute, patient will be having the peak headache. That is called thunderclap headache. That is always secondary headache. In subarachnoid hemorrhage, cortical vein thrombosis, arterial vein malformation, intracranial hemorrhages will also cause thunderclap-like headache. A patient having fever, arthralgia, rashes, in that case, you need to rule out arthritis, collagen vascular disorders, encephalitis. Next slide. First and worst headache. Again, you need to rule out subarachnoid, RCVS, intracranial hemorrhages. If patient is having a focal deficits like hemiparesis, visual distortion, aphasia, that time you have to rule out any intracranial space occupying lesions, CVTs, or arterial dissections. If headache is worsened by cough, exertion, or any sexual intercourses, again you need to rule out the vascular abnormalities, subarachnoid hemorrhage, Arnold Chiari malformation, or any structural lesion that are causing rise ICTs. And patient having any personality changes, altered mental status, or any consciousness alteration, you need to rule out CNS infections or exhaust. If patient is having any neck stiffness, again it indirectly indicates meningitis or subarachnoid hemorrhages. In case of postpartum condition, you all of you know like cortical vein thrombosis, press, carotid artery dissections, or pituitary apoplexy. These will present in the postpartum age group. Next.
Next one.
Is this speed is okay, or should I have to make it 2-speed or a... Hello.
Sir, speed is fine, sir.
Huh? This speed is okay, or should I have to like modify this?
Speed is fine, sir.
Hello.
Hello, sir.
Hello, tell me.
Sir, speed is fine.
Okay. You remember the criteria, that is SNOO 4 criteria it is called. This is a red flag for headache. If patient is having S, that indicates systemic symptoms and signs. N indicates neurological symptoms and signs. O indicates onset, that is sudden onset. Another O indicates older age, if age is more than 50 years. And pattern change, P is change in the pattern of headache. And another P is Valsalva malware or precipitating factors. One more P is positional aggravation. And last P is papilledema. This SNOO 4 criteria you need to apply for all the patients, those who are having headache. And if you are suspecting the patient, those who are having secondary headache, these things to be kept in the mind, because secondary headache line of management is entirely different from the primary headache management. Next slide. Again, the same slide, that S is systemic symptoms, N is neurological deficit, O is onset, one more is more than 50 years, positional, prior, postpartum, or precipitating factor. These things, SNOO 4, you need to remember all the time when you're sitting in the OPD or in an emergency room, because you need to rule out the secondary causes. Next slide. Okay. Next, duration of the headache. New onset headache always a warning bell. You need to rule out the secondary causes. If patient is acute onset, severe, first, worst headache is a sinister, like subarachnoid hemorrhage, vascular dissection, cerebral venous thrombosis, reversible cerebral vasoconstriction syndrome, acute hypertensive crisis, pituitary apoplexy will present like acute onset, severe, worst headache. Next slide. Again, second one is location and pattern. Patient might be having hemicranial headache or holocranial. Holocranial means either shifting, or either it may be right or left side or both the side. Sometimes patient like as you all of you know, cluster headache, hemicranial continue, all will these kind of headache will be side locked. So side lock headaches are always warrants the investigation because side lock headaches are almost associated with any structural lesions that are involving the hypothalamus or pituitary or any clivus. And third one is the patient is having any neck pain or shoulder pain that is radiating to head, that will also cause a headache. Most of the cervical spondylitis patient are rheumatoid arthritis that is involving the C1 and C2 joint, that will also cause us headache. That is called cervicogenic headache. These are associated with neck pain. Most of the patient, like around 75% of the patient, those who have cervical spondylitis will have the headache. Sometimes it mimics primary headache. And distribution of headache you have to see again, V1, V2 or V3. These also will mentioned. Any dental intervention prior to the onset of headache will also have migraine-like episode with headaches. Next slide. Again, the ice cream headache. This is also called ice cream headache. Whenever patient had cold items like ice cream or anything, that patient will have headache behind the ear and just above the frontal sinuses. And cluster headache, there will be purely side lock, or either right side or left side. Sinusitis headache will be around the sinuses. Tension type all over the head, predominantly frontal, tight band-like sensation, heaviness of the head-like sensation. Migraine patient will also have bilateral or unilateral presentation. Trigeminal neuralgia, like flash, like within second, episodic transient pains that are involving the half of the face. Okay, next slide. Supratentorial structures, most of these structures will be innervated by C2 and C3 nerve root. So most of the lesions that are causing the structural lesions in the C2 and C3, that will also causes the headache. Therefore, the pain from the upper cervical pain or the posterior fossa can be referred to anteriorly in front of the head. Next slide. Headache that spread into the lower neck and between the shoulder may indicate meningeal irritation due to either infection or any subarachnoid hemorrhage. It is not a typical benign progression. Okay, whenever you are sitting in the emergency or OPD, if a patient comes with the complaints of lower neck pain that is spreading downwards between the shoulder blade, acute to subacute onset, always you need to rule out subarachnoid hemorrhage or any meningitis. And in a headache, in a patient presented with acute angle closure glaucoma, patient will be having severe periorbital pain, color halos, and nausea, vomiting. Again, that would be headache secondary to acute angle closure glaucoma. Next slide. And in cardiac OPD or cardiac emergency, patient comes with a complaints of headache that is exertional. Whenever he walks for few minutes or few seconds, he is having the headache that is involving the neck and forehead, associated with some anginal pain. So you need to ask the anginal history also. Some of the patients will have purely headache on exertion. This is also called cardiac cephalgia, without having any anginal pain. They are telling like around 27% of the patient, those who are having cardiac cephalgia will be having only headache as the initial manifestation. So if you take a history properly, like patient comes with a complaint of exertional headache, again you need to rule out all these cardiac ischemic heart disease conditions. Next slide. One more entity, that is coat hanger headache, it is called. Patient feels a pain in the neck and shoulder in a coat hanger pattern. It is secondary to postural hypotension or any postural fall in the blood pressure whenever the change in the position of the patient. So always you need to ask if a patient is having the pain in the coat hanger pattern, and if he is having any orthostatic hypotension, that will fit in the diagnosis. If you treat the orthostatic hypotension, that time only patient symptoms will be better. Otherwise, if you give any simple analgesic, it won't be helpful. So history is very important, and location, duration is also important. And facial pain in trigeminal neuralgia, all of you know, side locked in a V1, V2 distribution, and facial pain sometimes triggered by opening up the mouth. Next slide. Okay. Again, you need to ask the history of diurnal or seasonal variation in the headache. Some of the headaches like raised ICT headaches, hypnic headaches, cluster headaches will be having the nocturnal incidence. Like most of these patients will be presented with history of nocturnal headaches. So if you elicit this history, you can rule out these kind of headaches. In raised ICT, patient will be having early morning awakening, early morning raised headache, will also indicate the raised ICT. And the cluster headache sometimes occur in winter season. That is, so seasonal history is also important. You need to ask both diurnal and seasonal variation of the headache in a patient presented with a headache. Next slide. And duration is also important. If patient having headache of duration 4 hours or more than 4 hours, you can label it to migraine headache. And trigeminal autonomic sepalgias are most of the headaches are less than 4 hours. Primary stabbing headaches are sometimes last for less than 10 seconds to 10 minutes. And hemicrania continua will have more than 24 hours attack. Paroxysmal hemicrania will have less than 30 minutes attack. Cluster headache usually up to 1.5 hours. So duration of the headache is also important to label different varieties of the headache. If headache persisted for more than 72 hours, you can call it as status migrainosus. As like your status epilepticus, status migrainosus also one entity is there. Next slide. And character of the headache should be also asked. In migraine patient will be having pulsatile or throbbing type of headache, and primary stabbing headaches will be have ice pick sensation like, and tags are stabbing like sensation. Tension type of headache would be have dull, fearless, heaviness of the head. These are the varieties or type of the headache. These two also be asked. Next slide. These are the following conditions that are associated with the thunderclap headache. As I told before, the headache within 60 seconds or 1 minute, that is called thunderclap headache. These are the common causes like vascular causes like subarachnoid hemorrhages, dissections, cortical vein thrombosis, RCVS, pituitary apoplexis, or hypertensive crisis. These all present with thunderclap headache. Next slide. Ottawa SAS rule, as all of you know, if a young patient with sudden onset headache, neck pain, altered consciousness, that to occur during the exertion associated with thunderclap variety, you need to rule out subarachnoid hemorrhage. Next slide. Then you need to ask for triggers like lifestyle, lack of sleep, irregular work schedule, foods like alcohol, chocolate, cheese, fragrances like perfumes, whether all these will be triggers the primary headache. Even after treating the primary headache with proper medicine, sometimes patient will present worsening of the symptom. It means not always to increase the dose of the medicine, you need to ask for the trigger factors. All these trigger factors also important in the management of primary headache disorders. Next slide. Other associated conditions, like you need to ask for vomiting, tinnitus, vertigo, cervical or cranial muscle tenderness in case of cervical artery dissection, ARA, autonomic features, Horner syndrome, Addis pupillar visual loss, or any transient visual obscurations. All these causes symptoms should be asked because these all the symptoms will be associated with most commonly associated with secondary headaches. Next. And associated with features like if patient is having any focal neurological deficit like HIV associated neurological deficit syndrome, radiculopathies, or any pulsatile throbbing type of headache in migraine, or any painful superficial temporal artery in elderly patients, that will be patient will be having giant cell arteritis, or any history of syncope, irritability, confusion, restlessness. These also be asked because most of the migraine patient will be having irritability, and cluster patients will be have inner restlessness, or any personality alteration, disinhibition, impulsivity, or any lack of awareness. These all complaints should be asked. Next. One more next symptom is ARA. This is the pervasive quality of the visual phenomena or sensory phenomena that do occur with migraine headaches, seizures, or any occipital lobe epilepsies. Patient will be having like bright zigzag lines appearance, voice nose, visual nose, palinopsias, double visions, inverted visions, because of involvement of occipital lobe and its connection in the cortical spreading depression mechanism. Pilopsia, this is called pilopsia because objects may appear closer. This is called pilopsia. Or if objects are appears further away, that is called telopsia. Or objects that are appearing smaller and moving further away, paropsia. These patient, most of these migraine patient will present like this: pilopsia, telopsia, paropsia, palinopsia. These are history to be asked is a part of ARA. Next slide. Most of the RS precedes the headache, and it can occur along with the headache also. Sometimes after headache also RS will come. So before labeling into ARA, you need to rule out any TIA, transient ischemic attacks, seizure disorders. These two conditions mimics ARA, but in TIA there will not be any progression of symptom. In seizure disorder, patient will be having other associated secondary generalization feature that will help to differentiate from the TIA, seizures, or any stroke-like episodes. It is difficult when a patient presents isolated ARA without headache. That time it would be very difficult to rule out whether it is ARA or TIA or any seizure disorder. That time you need to evaluate from all the aspects. Next slide. ARA, it originates most of the time. ARA originates from the occipital lobe. Sometimes it do occur from the temporal lobe and its connection. That will present with memory disturbances, visual agnosia, tinnitus. If it is from the parietal lobe, patient will be having paresthesias involving the upper limb and lower limb, visual illusions, hallucinations, and psychosomatic complaints. Next slide. If ARA originates from the frontal lobe, patient will be having executive dysfunction, motor dysphasias, depression, anxiety, or limb weakness. If it is from the hypothalamus, patient will have aning, food cravings, tiredness, mood changes, nausea, and hormonal imbalance and menstrual cycle abnormalities. Next slide. If ARA originates from the brainstem, patient will be having vertigo, tinnitus, ataxia, confusion, loss of consciousness. A gradual onset and progression over a few minutes is characteristic of migraine as compared to TIA, where sudden onset will be there. In case of TIA and seizure, patient will have sudden onset, non-progressive symptoms as compared to migrainous ARA. And usually these ARA persist for 20 to 30 minutes. ARA more than 60 minutes will lead to migrainous infarction, and sometimes it may mimic a stroke. Next slide. And you need to ask the precipitating factors like patient doing Valsalva maneuver, coughing, sneezing, laughing. That will increases the intracranial pressure, and posterior fossa structural abnormalities will be precipitated by these kind of maneuvers. So you need to rule out always secondary headache causes in a patient, those who presented with worsening of the headache with the Valsalva maneuver. Once if you ruled out, you can label it as primary cough headache. Next, the spontaneous intracranial hypertension is one entity is there. Like most of the time you might have seen post lumbar puncture due to the series of leg, patient will be having spontaneous intracranial hypotension. Patient will have complaints of headache whenever changing the position from the supine to sitting position or erect posture. Again it will improve after changing the posture to supine position. In case of raised ICT, patient will have increase in the headache whenever lying on the supine position. And sometimes physical activity might have aggravates the headache in case of migraine. Other stimulus like cold stimulus, external pressure induced headache, that will also lead to the worsening of the headache. By avoiding the cold and external pressure, we can prevent the migraine type of headache. Next slide. You need to ask the personal history and the family history in case of headache. Like excessive consumption of alcohol and smoking, that too again precipitate the cluster headache during the active phases. And family history is also important in some of the genetic migraine, familial hemiplegic migraines, CADASIL. Patient will present with isolated headache or associated seizure, headache, or focal deficits. So family and personal history is also important in a headache history taking. Next slide. So during the follow-up, you can ask like any worsening or improvement or any modification of the headache. You can use the various score systems are there, MIDAS, HIT6, or headache diary. Also, you can provide the patient by asking the patient to write the date of attack, duration of the attack, severity of the headache, previous precipitating factors, triggers, medication what he has taken, and how does it relieve. These you can make it, and next visit you can modify the dose or any adding the extra drugs. That headache chart would help. Next slide. Again, you need to ask the medication overuse. Sometimes like caffeine, codeine, triptans, oral contraceptives, vasodilators, nitrates, antiarrhythmics that do precipitate the headache. If you like avoid these drugs, patient will have good benefit. Otherwise, if you continue these drugs, will patient will have worsened headache. Again, it will be difficult to treat the conditions. You need to ask detailed medication headache. Next slide. And in special group like patient older, elderly age, more than 50 years, again you need to rule out stroke or giant cell arteritis as a leading causes of the elderly headaches. Next. In case of headache in pregnancy and postpartum, you need to rule out PRES, cortical vein thrombosis, reversible cerebral vasoconstriction syndrome, pituitary apoplexy. Whenever we get the reference from the OBG in the postpartum period, patient is having new onset severe headache, these to be kept in the mind. You should not label it a primary headache or a simple headache that is give worse term. That would be problematic again if patient land up in the trouble. Headache in children is very difficult. There are multiple varieties of the headaches are there in children like abdominal migraine, cyclical vomiting syndrome. Most of the headaches in the pediatric age group are short duration. Ideally in the adults it would be more than 4 hours. In children 2 to more than 2 hours. 2 to 4 hours also we can label it in a migraine duration. Most of the patient will be have benefit from the sleep. In the pediatric age group, again, you need to see for any excessive intake of chocolates, cheese, caffeinated drinks. All these contains monosodium glutamate, which is the trigger factor for the migraine. In a children with intracranial tumor, nocturnal and morning headaches are most common. So, if a pediatric age group patient presented with history of nocturnal or early morning severe headache, you need to rule out always intracranial space occupying lesions. Next slide. Again, you might get reference or you even need to cross reference from the other specialties. Like in sinus infection, patient will be having the headache. And in case of anal glaucoma, patient will go to the ophthalmologist. And in sphenoid sinusitis, patient will have vertex again. Again, if you treat the simple primary as a primary headache, again patient will be having the sphenoid sinusitis that will later complicate into involve the meningitis also. So you need to rule out the secondary causes. You need to take the consultation from the ENT, optal, and from any other ocular causes also to be ruled out. Again, the same headache that is linked to the headache. Patient will be having facial pain, pressure, congestion and fullness, nasal discharge, nasal obstruction, smell abnormalities, fever, and worsening with the movement and coughing. Sometimes in 50% of the patient will be having fever. This will help you to treat the sinusitis and make the patient free from the headache. These are some videos. Can you play it? I think it's not playing. Okay, I will share in the WhatsApp group now. One is cluster headache was there, and one more I'm not remembering.
That is not coming.
Okay, no problem. I'll share in the group. If anybody having doubts, kindly ask. Any particular topics you want? If you need any particular topics for your exams or any clinicals, kindly message me in the group so that I can prepare. Let me know, like whenever you're planning for presentation, 2 or 3 days prior to the presentation, you generate the ID and message me.
Hello, sir.
Tell me.
Sir, treatment protocol for migraine, sir. What is the first drug of choice? Then what we need to look for response?
Okay. First, you want to like acute abortive attack or prophylaxis you want?
Sir, acute, sir. Acute.
Hello.
Acute,
In acute
sir.
attack, to abort the acute attack, you can use simple analgesics with naproxen, diclofenac, paracetamol, ketorolac, or ibuprofen. These are the NSAIDs which can be used in the acute attack. If not subsides, we can use triptan derivatives, sumatriptan, rizatriptan. These drugs can be used. Even after that, also acute attack is not relieving, means you can use levetiracetam, sodium valproate, or stat dose of steroids. Again, even after that loading dose of anti-epileptic, also still patient is having migraine headache, you can give greater occipital nerve blocks. In prophylaxis, again, you need to look for the patient's profile. If a patient having depression, low mood, along with one migraine headache, again, you can consider for amitriptyline. If a patient, male patient with seizures, mood disorders, patient having migraine headache, that time you can choose sodium valproate. If patient is obese, idiopathic intracranial hypertension is there, that time you can use topiramate. Depending on the side effect profile, you can choose the prophylactic anti-migraine medications. In refractory cases, you can use botulinum toxin also. On the skull, you can make it around 25 to 30 square boxes. 80 to 100 units of botulinum toxin will be divided equally. We can infiltrate on the scalp. In the last resort, this is a lot. Even after all these medicines, if the patient having frequent migraine attacks, these can be botulinum toxin also be tried. And recently, non-invasive modalities are also available, like transcranial magnetic stimulation or supraorbital nerve stimulating devices. All these things are also available.
To start prophylactic, sir. The criteria to start a prophylaxis.
Okay, good question. One, if a patient is having, again, migraine is classified as episodic migraine and the chronic migraine. Episodic means if the patient is having 4 or less than 4 attacks, that to non-disabling headache, and the headache which are like one that is affect the routine activity, that is not affecting any routine activities of daily living. Say for an example, if a young female, she is presented with like migraine episodes headache, only 2 to 3 episodes in a month, that is not disabling her routine activities of living. That time no need to start the prophylactic medication. You can give just symptomatic acute migraine aborting agents. If a patient who is presented with more than 4 attacks, headaches in a month, or more than 15 days of headache duration in a month, and disabling headache, that time you need to start the prophylaxis.
Okay, thank you, sir.
Okay. Any other questions?
Ganesh,
Sir.
hello.
Sir.
After 3 months of giving prophylaxis,
Sir.
okay, if patient responds okay, then reattacks, if again reattacks of migraine are there, so
Yes, sir.
how to, we can start with same regimen, or for how many months we have to continue?
Sir, ideally 3 to 6 months is recommended. Minimum 3 to 6 months of adequate dose of prophylactic medicines should be given. But most of the patient around this is a 70 to 80% of the migraine patients will go for relapse even after treating for around 6 months. But another 20 to 30% of patient will be keep on having these kind of attacks. We have seen like around 8 to 10 years of headache patient, 10 to 12 years, 5 to 6 years, like 20% of the patient will be having these kind of attack even after 6 months also, sir. That time you need to decide whether to continue the prophylactic drug or not, depending on the attack rate.
Attack rate.
Minimum
Still,
3 to 6 months mandatory.
If the patients are continuing the attacks of more than 4 attacks per month, also we have to continue, or we have to maintain the dose for lifelong?
Sir, more than 4 attack means again it will come under chronic category, sir. Less than 4 is like episodic.
Chronic attack, okay.
4 to 8 we can accept.
Okay.
More than 8 is like mandatory to treat.
Mandatory. If I'm telling after giving the prophylactic for 6 months, again patient coming
you
after
start tapering the dose, sir. Like suddenly you don't stop. Mandatory 6 month regimen give. Like say for an example, if you're giving propranolol around 80 mg, make it 60, make it 40, make it 20, keep on reducing the dose. If patient not getting any attacks, then stop the prophylactic anti-migraine medicine. Advise the lifestyle modification and tell the patient to avoid the trigger agent. If that relapses, that's well and good. If patient not have any relapse, again he is having the frequent episodes of headache, again you need to reinitiate or escalate the dose of previous prophylactic agents.
Okay. Thank you.
Recently, one newer drug has come, sir. Lasmiditan is recently approved drug. You can use in like cardiac patients also, subarachnoid hemorrhage patient also, and old stroke patients also. And the levetrestam also recently approved by the FDA for acute termination of migraine attack, status migrainosis. And oral anti-CGP peptides are come, sir. Oral and injectable CGRP peptide also come. Calcitonin Z related peptide antagonist also comes.
Yes, calcium. Okay.
Any other questions? Okay, next week we'll decide like general physical examination neurology. I will take a class. Is that okay, or any particular topics you want?
Sir, as per the timetable, will go, sir. Next class.
Hello.
Sir, general physical examination, sir.
That would be better. I think that GP in neurology will take next class. Okay.
Yes, sir. Yes, sir.
Okay.
Yes, sir. Thank you, sir.
Okay. Bye.
Ganesh, thank you.
Thank you, sir.
Thank you. Okay.